Welcome to MedEd's production of the SCRN exam review. My name is Kendra Menzies Kent, and the title of this module is Acute Care Ischemic Strokes. What we're going to talk about during this module is now that this ischemic stroke patient has moved through the emergency room, has been recognized as having a stroke, and has maybe even had their TPA initiated, they are now coming to the ICU or to acute care telemetry monitored beds, all right? And that's where we're going to start out with this patient. So we're going to talk about now the acute management of this patient following an ischemic stroke. When we think about the acute care, all right, the recommendation as these stroke patients, particularly the higher acuity, need to go to a stroke center or a stroke unit that specializes in stroke care, or a neurocritical care unit. What has been shown in the literature is that the neurological deterioration of a stroke patient can occur within that first 24 to 48 hours, and it's typically going to be seen in about 25% of our ischemic stroke cases. So that's why they need to go to a monitored situation. They need to go with the nurses and the care providers that specialize in strokes and neurocritical care. The goals of the treatment now in the acute care area are going to be observing these patients, being able to recognize any changes in the patient's condition that might prompt or initiate medical or surgical interventions. The second goal in the acute care is going to be with the observation and treatment is to reduce the risk of having a cerebral bleed following the administration of the fibrinolytic agent of TPA. So it's the recognizing of the bleed if it occurs and knowing how to intervene and how to intervene quickly for that bleed. A third goal is to facilitate the medical or surgical measures that are aimed at improving the outcome after a stroke. And we're going to talk about these several measures that we use, and we're going to talk about that in another module. It's going to begin measures to prevent subacute complications. Some of the biggest reasons for death, morbidity, worsening of neurological outcomes is going to be that they develop a complication. So again, a lot of our care in the acute care area is to prevent those complications. Another goal is to initiate now long-term therapies that are going to help prevent the reoccurring stroke. And this would be our prevention for secondary strokes. And last, we're going to start efforts to restore neurological function through rehabilitation and provide very good supportive care. And rehab begins as soon as they are admitted. All right, so it's not just talking about rehabilitation once we send them out and discharge them to a rehab facility. Rehab starts early, and that's what we're going to look at when we talk about the rehab. Like I said, when you look at stroke patients and their complications, the stroke severity, when we look at outcomes, neurological outcomes, a lot of times that is based on the development of complications. And usually if they're going to develop a complication, it's going to be within the first 4 days of their admission. So that is that highest acuity time period. That is the time period for very close observation, for initiating a lot of these preventive measures that we're going to talk about during this module. Some of the examples of complications that have been shown to worsen outcomes and increase mortality on our stroke patients are going to be pain, fever, a progression of the stroke itself, or urinary tract infections. And we're going to talk a lot about those as well. That's been talked about, the urinary tract infections and urosepsis. We talk a lot about that with any of our ICU patients. But with stroke patients, I'll give you some examples in a little bit. It's even more important on them. All right, we see a very high incidence of that. So let's start out with, again, the patient comes into the ICU. We get them on a cardiac monitored bed. They may, if they were a candidate for the TPA, they may still be getting their TPA infused during that 1 hour infusion. So we will be continuing their thrombolytics, and again, we're going to be continuing those frequent vital signs and neurological assessments that we talked about in the hyperacute module. During this period and after the infusion, That blood pressure on that patient is very important. We want to keep the blood pressure below 180 systolic and below 105 diastolic. Because if this patient again experiences hypertension, it's going to increase their risk of intracerebral hemorrhage following that TPA. So we are going to maintain their blood pressures down. Again, we're still going to allow perfusion, so we don't want them hypotensive, but we do want to keep them less than the 180 systolic. And like I said, close observation, frequent vital signs, and frequent neurological assessments. The most frequent time period, if they're going to have a complication of that TPA, if we're going to see an intracerebral hemorrhage, typically it's going to occur within that first 24 hours of giving the medication of the infusion. The vast majority of those fatal hemorrhages that occur with the TPA are going to occur within the first 12 hours. So again, it's close observation. It's nurses that are specializing in strokes that will be taking care of these stroke patients with this. Another area that is recommended in this acute care area is to manage any hyperthermia. What we find is that a lot of your stroke patients are going to become hyperthermic, and you may see that within the first 4 hours of admission following their stroke. And a lot of it is a neurogenic fever. Later, 24, 48 hours, if they increase their temperature, it may be fever related to an infection. But that early increase in temperature, a lot of times that is associated with the neurogenic fevers that we talk about, the hypothalamic injury on this. So we know that hyperthermia can worsen neurological outcomes. So we're very aggressive at managing their body temperature and making sure we keep them in the normal body temperature range. There's some discussion in the literature, there's some studies that have been looked at on therapeutic hypothermia, dropping their body temperatures down to that 32, 34 degrees Celsius that is used in post-cardiac arrest patients. And to date, there are no studies that really show that that benefits our stroke patients. So it is not recommended to do the therapeutic hypothermia on our stroke patients at this time. There are still some studies being looked at, but at this time we want that normal body temperature range. Now, what can we use to do it? Well, we can do external cooling. We can even do internal cooling. I've had some stroke patients that we've had a hard time getting their body temperature because of the neurogenic fever into the normal range, and we've also done that invasive through the IV catheter hypothermic techniques. But again, our goal was not to put them into therapeutic hypothermia. Our goal is always to put them into that normal body temperature range. The other thing we can, of course, do are the acetaminophen. And actually the IV acetaminophen may actually work very well with these temperatures, and that's an option for bringing their fever down. All right, but we want to monitor their body temperatures closely, and we want to be ready to lower or put it in that normal range of a body temperature. The other question always comes up is, what do we do with the glucose? Again, hyperglycemia, we know, worsens neurological outcomes if they experience an episode or persistent hyperglycemia that first 24 hours following their ischemic stroke. But we also know if they are hypoglycemic, again, if they have episodes or frequent episodes of hypoglycemia, that can also worsen their outcomes. The brain is very dependent on the glucose that it gets on a regular basis. It can't store that glucose. So really, when we look at our stroke patients, we don't want either extreme. All right, we don't want them hypoglycemic and we don't want them hyperglycemic. So where do we stand right now on the glucose? If their glucose is less than 60, then they need to be treated with dextrose. All right, so again, we want to monitor their glucose on a frequent basis and administer the dextrose if needed to bring their glucose back up into the normal range. Typically, we don't see a lot of glucoses in a stroke patient. If you do, it's probably because the patient is a diabetic, maybe on their diabetic medications, and of course now with all the physiological changes going on and their diet changes, their NPO, what we'll see sometimes it kind of kicks in and it drops their blood glucose down. Otherwise, typically what you are going to see is the hyperglycemia. This is a stress response, all right? We see it in a lot of our higher acuity patients. We can see it in our stroke patients, but they get hyperglycemic, all right? So that's the direction we tend to see it go. The current recommendation is to maintain their serum glucose in the range of 140 to 180. This has changed, up and down over the last several years. You know, it started out where we wouldn't treat it unless it got greater than 180, and then we saw all the studies showing that hyperglycemia worsens outcomes. So a lot of places went to what's called strict glycemic control, and that is keeping this glucose within that 80 to 120 range. The problem with that, and the studies have shown this, is that when you try to keep them in that really, really strict range on these non-diabetic patients that are hyperglycemic, we have episodes of hypoglycemia. And like we said, hypoglycemia can also worsen outcomes. So because of that titrating of that insulin and trying to maintain that strict glycemic control, we were getting the other direction often, and was actually showing that it may worsen outcomes as well, increase mortality. So we're back now to saying we don't want them hyperglycemic, we don't want them over 180, but we don't have to get them down into the normal range, and so that's why we look at maintaining them between the 140 and the 180. Another area that we get into is what do we do with their blood pressure? All right, we said in the hyperacute period that if they are a candidate for the TPA, then we get it less than 185. If they're getting the TPA, we want to maintain it systolic less than 180. And we also said in the hyperacute module that if you have a patient that is not a candidate for the TPA, then we're not going to treat the systolic unless it gets greater than 220, or the diastolic unless it gets greater than 120. But that's within that initial period. So the question comes in is, now that they're admitted, when do we start managing their blood pressure? And the rule of thumb, the recommendations are after about 24 hours. All right, so again, if they're on the TPA or receive the TPA, we keep it down less than the 180. If they did not receive the TPA, then we allow them to remain hypertensive as long as their systolic is less than 220 and their diastolic is less than 120. But after 24 hours, this is now where we'll look at starting to, if they remain hypertensive, starting to lower that blood pressure. Now the key is we don't want to bring their pressure down fast, because that's going to affect cerebral perfusion, and it may actually cause the hypoperfusion and greater ischemia. So we bring it down slowly. The recommendation is once the 24 hours is done, is to start reducing the blood pressure by 10-15%. All right, so it's slow over time to do it. This is also the time if you have somebody who's a chronic hypertensive patient that is normally on an antihypertensive at home, this is the time now 24 hours later that we look at starting them back on their antihypertensive medicines that they were on at home. All right, so we may start to introduce them at this point in time. Most patients that are not chronic hypertensive patients will actually start to show that they're going to lower their blood pressure in that 24-hour period anyway. So a lot of times we just watch them, and they'll start to bring their blood pressure down, and we just watch them, you know, and observe them. But if they continue hypertensive, we may have to intervene with that. Currently, there is no data, there's no recommendation that will guide the selection of the antihypertensive that can be used for lowering the blood pressure. The one thing we do look at is that if you use something that is more short-acting and titratable, you have a little bit more control if the pressure drops a little too low during the lowering of the pressure, that we can stop the infusion. Being short-acting, the pressure will come back up. But other than that, there's really no data available. All right, so it would be up to the clinician's experience and decision on what they want to use as their antihypertensive. When we get into talking about the neurological medications, we'll talk a little bit about the different drugs that can be used, all right? And in that module, we'll go back over that. Now, what do we do if they went the other direction? What do we do if our patient is hypotensive? Well, the answer is, again, persistent hypotension, all right? Persistent meaning that they are hypotensive even though we've given them fluids, we've rehydrated them, we've put them into a normal volume range. If they remain hypotensive at that time, then they may require a vasopressor, all right? And part of it, again, is perfusion. We know that that's one of those independent factors of a poor outcome in a stroke patient is if they're hypotensive, all right? So we want to get their pressure up in those particular cases, and if volume doesn't do it, then we might look at putting them on a vasopressor. What you have to keep in mind is that's an unusual situation again. If I have a patient that comes in that's an ischemic stroke, and they come up to the ICU and all of a sudden they drop their blood pressure, I'm going to treat the blood pressure, but we're also going to step back and say why. You know, what is going on with this patient? Why is their blood pressure dropping? Because one of the things we've talked about is that when somebody has a stroke, they can also have an acute MI at the same time. So we want to think about cardiovascular. Are we having a cardiovascular complication? Are they in an acute coronary syndrome? Do they have congested heart failure? You know, is there something else going on with this patient besides just a stroke? All right, so again, we're going to treat the pressure, but we're going to look for the underlying cause for that. Now, the other discussion that is going on in the literature and the research studies and our stroke conferences is, do we want to induce hypertension in a patient that is a normal blood pressure? All right, so we talked about what to do with a high blood pressure, and we talked about what to do with a low blood pressure, but we haven't really mentioned what to do if this patient's blood pressure is kind of in that normal range. And there are some studies, very small subset of patients, in an ischemic stroke in an early period has shown some modest benefit from driving their pressure up with a vasopressor. But currently, there's not enough studies that show drug-induced hypertension used on patients with normal blood pressures in an ischemic stroke is going to benefit the patient. So right now, the recommendation is that we need more studies. We need to do more clinical trials before we actually put it as a recommendation to do for our stroke patients. All right, so we will be looking at that still, but currently right now we allow their blood pressure to be where it is without putting them on a vasopressor and driving it up. The other area that's looked at in potentials for strokes is the use of high volume albumin. Albumin, we think of it always being as that colloidal oncotic pressure that's going to help kind of pull fluid. The other thing that's been found on albumin is that it has some neuroprotective effects to it. So it's going to protect the brain potentially during a period of ischemia, all right, with its ability to reduce the oxidative stress that occurs during the ischemia. Preliminary studies again suggest that the neuroprotection with this high-dose albumin may benefit the patient. But again, based upon our recommendations, we don't have enough research to really back the practice yet, and currently we require more further research on this. But if you hear anything about the albumin or they start talking about doing it, it's still looked at as it being a neuroprotective. So it's not as much to give them volume. We're still doing that with a lot of normal saline, but it's more for its neuroprotectiveness that may benefit the patient. All right, what else? Supplemental oxygen. Again, it's as needed. We don't recommend through our guidelines that every patient is put on supplemental oxygen, but every patient needs to be monitored. All right, they need their pulse oximetries, they need to be monitored for their O2 sats, and if their O2 saturation decreases less than 94%, then they need to be placed on supplemental oxygen. So again, we don't need super oxygenation levels, but we really don't want them hypoxic because again, hypoxia is going to worsen neurological outcomes. It's going to worsen the ischemic insult that has been going on with the stroke itself. Anticonvulsants, where do we stand on those? If the patient has a seizure, then we treat and manage the seizure like we would any other patient that has a seizure. So if they have a seizure, then we would put them on an anticonvulsant medication. We're going to treat the patient during the seizure just like we would any other patient. If they go into status, it'll be the same thing. We'll start out typically with the benzodiazepine, followed by a phenytoin or a fosphenytoin. You know, we'll follow our line of medications. So we treat them like we would any other neuro patient. Where it's different and where some changes have occurred with recommendation is that they do not recommend prophylaxis anticonvulsants. In other words, just because the patient comes in as a stroke patient doesn't mean we need to put them on an anticonvulsant if they've not had a seizure. All right, so we wait to see if they are going to have a seizure. If they do, we treat it. If they don't, then they do not need the prophylaxis anticonvulsants. The other thing is some of our patients, the higher acuity patients, following this large severe stroke is also going to get a lot of cerebral edema. We see combinations of vasogenic cerebral edema and cytotoxic cerebral edema. And that cytotoxic cerebral edema is intracellular, and it's due to the ischemia injuries that have happened to that brain. So we know these patients are at risk for an increased ICP. Major, like I said, larger strokes have the highest risk for increasing their intracranial pressures. So some of these patients are going to require ICP monitoring. In the module with the hemorrhagic strokes, I do go over ICP monitoring, so you will get the actual discussion on the different types of ICP monitors and where to put their ICP at. But it will be in the hemorrhagic stroke component of this acute care module. But I do talk a little in this one on, so we're monitoring, patient's ICP does go up, now what do we do? You know, what are some of our interventions? And again, we go to say that on a stroke patient, we're going to use the same interventions we would on any other neurological patient that has an increased ICP. So if you work with traumatic brain injured patients, and they have some really good guidelines on traumatic brain injured patients on how to lower the ICP, it'll be the same thing with our stroke patients that have that increased ICP. One of the things we can try are your osmotic diuretics, like mannitol, something to increase serum osmolality, to pull the excessive fluid into the vascular space. And again, we're going to talk a little bit more about mannitol when we get into our neurological medications. We can also use hypertonic salines. Hypertonic salines have an increase in tonicity. You can use a 3%, a 7.5%, there's 23%, but the higher the percentage, the more concentrated the solution is with the sodium chloride. And it works a little bit like your mannitol in the sense that it's going to increase serum osmolality. So it's going to work like mannitol. It pulls fluid into the vascular space so that we lower the cerebral edema. The difference is when we talk about mannitol, mannitol is also an osmotic diuretic. So when you give them mannitol, they're going to pull fluid, but then they're going to diurese. And the problem sometimes is they diurese excessively, and you now have a hypovolemic patient. And again, we don't want hypovolemia because it affects cerebral blood flow. So sometimes you're having to give fluid back to those patients. The hypertonic saline may actually do better in that area because it's not as much of a diuretic, so you don't always have to replace their volume losses with it. All right, but it's an option to lower the ICP. The other thing they can do is place the intraventricular catheter, and again, we'll talk more about that, and drain off the excessive CSF, removes a volume from the cranium, which helps lower the ICP. Mild hyperventilation. We don't recommend routinely hyperventilating a neuro patient. All right, if you think of the CO2, just as kind of a review again, when you think of the CO2, CO2 is a very potent vasodilator in the cerebral circulation. So if the CO2 goes up, we vasodilate in the brain, and when you vasodilate, you have more blood volume, and if I have more blood volume, then I have an increase in ICP. So we don't want patients hypercapnic. So we used to hyperventilate them and get the CO2s very low. Problem is now when you get a CO2 low, when you make them hypocarbic, they will vasoconstrict in the cerebral circulation. You have less blood volume, so yes, it does lower an ICP, but the problem is it will worsen outcomes if you get an extreme hypocarbia followed by that hyperventilation, and that's because by vasoconstricting, it decreases cerebral blood flow. So what we stand at and what we talk about when we say mild hyperventilation is that if the mannitol doesn't work, if putting the head of the bed up draining off some CSF. If all of these, your first line interventions don't work to bring that ICP down, then we can do what's called mild hyperventilation, and that would be to take them a little bit lower than normal, all right? So you might put them between 30 and 35. A lot of times we aim for right around that 32, 33 range, and so you're going to hyperventilate and bring them slightly down. It lowers their ICP, but because it's not such a low CO2, you still have some perfusion. All right, so again, it's not your first line, but it can be used as a second line intervention to lower someone's ICP. From there, they can do decompressive surgeries, and there has been some studies with stroke patients on that, and that's just doing a craniectomy. All right, they go in and they remove a section of the skull, because remember the skull's that box, there's no room for expansion, so they remove a little bit of the skull, which allows for some room for expansion and can help lower the intracranial pressure. The one thing that is no longer recommended in either our stroke patients or a traumatic brain injured patients are steroids, all right? Because steroids used to be thought to lower the incidence of cerebral edema, but the complication rate is higher and it's never been shown to improve outcomes. So they currently do not recommend the use of steroids in our patients for lowering the ICP. Another issue we get into is when it's time to feed our patients or take their oral meds, and these are the swallow issues. We mentioned it a little bit in the hyperacute module that we need to perform a bedside swallow eval before we give them a medication with a small sip of water. And we're going to look a little bit more in depth at this swallow issues our patients can have. So again, we can do that bedside evaluation. But remember, they can still be aspirating, and that's really important to understand that. I can do my whole risk for dysphagia, and I can still have this patient still doing silent aspirations, and that's where we really like to push that there's a speech therapist involved in this. The biggest concern is if they do aspirate, or even these little minute aspirations, silent aspirations, puts them at a higher risk for a pneumonia. And of course, if they develop a pneumonia, they have a longer length of stays and higher mortality in their hospitalization. So what are some things we would be kind of very high suspicion that they're going to have a swallow abnormality and make sure that the speech consult's done? Number one, if they have an abnormal gag reflex, impaired voluntary cough, you have somebody that has a little dysphonia, their voice sounds not quite right. Give them a little sip of water, they get kind of a wet sound to their voice. An incomplete oral labial closure. If this person's high NIH stroke scale, that means they have a greater severity of their stroke. They're more likely to have the dysphagia. And then any of the cranial nerve palsies, because remember the swallow and gag is part of your cranial nerves that branch off of the medulla. So we think about cranial nerves 9, 11, and 12 are our big ones for swallow, gag, and the ability to move the food around in their mouth with their tongue. Just a little word of warning, even if they have a gag reflex, and like I said, even if it looks like they're swallowing okay and they're not choking, they can still be aspirating. All right, so we do have to keep that in mind. The speech therapists, when they come in and they do further testing, a lot of times they're going to use the video fluoroscopic evaluation, or they can use a fiber optic endoscopic evaluation of their swallow. All right, so they're actually looking and not just listening or watching for signs of a swallow abnormality. So we do want to make sure the swallow is assessed and all their appropriate referrals are done on our patients. Like we said earlier, continuous cardiac monitoring. They can have arrhythmias. Fatal arrhythmias can actually be a result of death. Some of the medications we put them on may have a higher incidence of cardiovascular complications. So again, we want to do our continuous monitoring on them. Nutrition's important. Even the IV fluids up front initially, even if we don't start the food, any sort of feeding within that first 24 hours, make sure they're well hydrated. We know if they get dehydrated, not only does it affect cerebral blood flow, but it also increases their risk they're going to clot. And if they clot, then they're a high risk for our VTEs. We'll see a greater incidence of your DVTs and your pulmonary emboli on these patients. So well hydrate them to help lower some of the complication rates. And then they do recommend that we start, if they're not able to take oral intake, patients not awake enough to do it, or they have a swallow abnormality initially that they're not able to take oral intake, then what we want to look at is an early NG tube feeding. All right, tube feeding has been shown better than your TPN at protecting the GI tract and lowering the incidence of gram-negative bacteremias. So we want to put the NG tube in and feed them through an NG tube. And they've shown again that early feeding can substantially reduce the risk of death in our stroke patients. All right, so we need to have the good nutrition. A lot of times if they are not waking up, we are looking at transferring them, trying to get them to rehab, discharge. At that point in time, a lot of times they'll talk about doing a PEG tube, the actual percutaneous tube that goes into the stomach. And that is all right, because I know a lot of our organizations, our hospitals, our rehab won't take an NG tube because it's easily dislodged. If you look at the studies, though, just be aware that actually feeding in the NG tube shows as good of a functional outcome as feeding in a PEG tube. All right, but again, I know that it's the securing a lot of times of the NG tube, the necrosis of the nose. We tend to a lot of times use the PEG tube as well. And then bowel management. They can develop an ileus, they can develop constipation, and then they get the obstruction, and sometimes even leads all the way to a perforation. So we need to make sure we have very good bowel management on these patients. Monitor neurological status even after the infusion, even after we're done with those frequent neural assessments for our fibrinolytics. We still have to do frequent neurological exams, and it's not unusual to take our neuro patients frequently to CT scans, to MRIs, to do follow-up assessments of their neurological status and what injury's been done. Begin early mobilization unless there's a contraindication to it. Get these patients moving, range of motions, get them up, get them on the side of the bed, sit them up, stand them, walk them, anything we need to do to get this early mobilization. We know with early mobilization you can lower your incidence of pressure sores, of VTEs, of contractures, muscle atrophy. It actually helps improve their mentation. If you think about it, if someone's just laying in the bed, what are they looking at? The ceiling, all right? You get them up, you walk them, you move them around. It helps with their orientation, all right? Sometimes it can show to improve mentation. So we do want to get these patients moving. Do be careful, of course, going from the sitting to a standing position or lying to a sitting. They can get hypotensive, and if they get hypotensive, then they may have a little bit of change in their neurological status, all right? So you kind of want a little bit of support when you're doing it, but early mobilization can improve outcomes in these patients. We also want to prevent infections. We said those first 4 days are so important on our stroke patient. This is also the period that we see our higher incidence of our infections starting. They can have hospital-acquired pneumonias. If they're on a ventilator, they may be prone to ventilator-associated pneumonias. We want to look at how do we prevent that, because anytime they develop a pneumonia, it's going to increase the mortality in our stroke patients. Remember, they're high risk for aspirations. All right, so that's one prevention, is to look at their swallow evaluation. We can provide good pulmonary care, make sure if they are on bed rest, the bed moves. We can do all the vibration on those beds. And then, like I said, if they're not on bed rest, then we want to do early mobilization. If they're intubated and being ventilated, then we want to follow all of the ventilator-associated pneumonia prevention protocols on these patients. And one of the big ones, of course, is good oral care. Very good, frequent oral care can help with the prevention of some of these pneumonias, because then they don't aspirate some of the bacteria that may be in the mouth. UTIs are probably another really big area on our stroke patients for an infection. They can occur, depends on the study, anywhere from 15% of our stroke patients up to 60% of our stroke patients. A lot of it has to do with the catheter. I know the big push is what now? Don't put it in if you don't have to, and get it out as soon as you can. All right, that's what we're all saying on all patients. They don't need a Foley, don't put it in. And if they have a Foley, get it out as soon as possible. And it's the same thing on our stroke patients. I do also want to give one other reminder on a stroke patient that I think people don't always stop to think about. We do see a higher incidence of UTIs on strokes than other ICU patients or floor patients. One of the reasons I really believe, and I've seen this a lot in the hospitals I work in, is they go to CT scans and MRIs more often than most of these other patients do. And what do they do when they travel? Or they put them in a scanner. Pick the Foley bag up and they put it between the legs. All right, and there's your reflex back into the bladder, and there's a UTI. So we need to make sure that the Foley bag stays below the patient, or if they're going to put it up in the bed, then they need to clamp the Foley before they do that so we don't get the reflex of urine up into the bladder. All right, so little things like that can make huge differences in these patients' outcomes. There are alternatives. We have external catheters for some of our male patients. We have incontinence pens. We have intermittent catheterization. So there are some alternatives to an indwelling catheter as well. VTE prophylaxis. This is one of our core measures. And again, we'll talk more about core measures in the module on our quality of systems. But when you look at VTE prophylaxis, PEs account for about 10% of the stroke deaths. All right, so that's pretty major. And again, these patients tend to be immobilized. If they have a paresis or paralysis of their lower extremity, that increases their risk of a DVT, even with some of our mobilization techniques. If they have a PICC line placed for their management, the PICC line shows a higher incidence of upper extremity DVTs. So these patients are at a higher risk for a VTE, and it is recommended they receive VTE prophylaxis. So the options for the prophylaxis can be the administration of an antithrombotic agent like sub-Q heparin, sub-Q low molecular weight heparins. If it's an ischemic stroke, most of the time they will go ahead and look at doing the antithrombotic agents. If it's a hemorrhagic stroke, then usually it is just the mechanical devices for the first several days of their hospital stay. If it's an ischemic stroke, besides giving them the sub-Q, they can also have the external compression devices, all right, the pumps, as well as if they have a DVT or they're a very high risk for a DVT, then they can have a filter placed in the inferior vena cava. So if they form a clot, throw a clot, it doesn't go all the way up into the lungs. The compression devices, the one thing I do want to comment on that is we have the TED hose, and then we have the actual the sequential compression devices. If you look at the literature and the studies on this, the TED hose is very controversial. Some of the guidelines for VTE prophylaxis keeps the TED hose in there. Some of them actually say that they are contraindicated. So it's going to be a variety of different guidelines you look at. But there are some studies that show TED hose can increase the incidence of a DVT. And you think about also skin breakdown. And a lot of it's because they don't fit appropriately. So appropriately fitting TED hose would be appropriate on our patients. But if they're tight and they're constricting, they may actually be complicating the patient, causing complications. So we want to make sure if we're going to use them, they fit appropriately. Otherwise, we can use just the compression devices without the TED hose, all right? And those work just as effectively on that, if not better. If you have a patient that the physician feels is a very high risk for a bleed, and they don't want to put them on like heparin or low molecular weight heparins, then they can use an aspirin. The aspirin, the antiplatelet drug, does not prevent as many VTEs as your anticoagulation therapy does, but if they're high risk for a bleed, the aspirin might be the better route. All right, so it's considered in our guidelines to be a reasonable alternative on a patient that has a high risk for a bleed with an anticoagulation therapy. And the last little bit, of course, is to remember a little of our module on risk factors and patient education. Don't forget that is all a part of our acute care management. Begins on day one, all the way through discharge. All right, we need to make sure we have really good discharge planning, discharge instructions when we send them home. And also remember we need to do that early initiation of secondary stroke prevention. All right, and we talked about that earlier in the other module. So I'd like to thank everybody for being here today. talking about the beginning of this acute care management, working with these ischemic patients in the ICU, out on our telemetries and our med-surg floors prior to discharge. Thank you.